You're listening to the ATS Breathe Easy podcast, brought to you by the American Thoracic Society.
Hello and welcome. You're listening to the ATS Breathe Easy podcast with me, your host, Dr. Amy Attaway. Today, we will be speaking about nebulizers, usage in COPD. And joining me today is an expert on all things COPD, and Dr. Anthony Anzueto. He is a professor of medicine at the University of Texas Health Science Center and chief of the pulmonary section for the South Texas Veterans Healthcare System in San Antonio. Dr. Anzueto is an active member of the GOLD organization and has helped develop many iterations of the GOLD guidelines for COPD. He also has extensive research experience and has been the principal investigator of numerous large multi-center clinical trials, including the most recent ENHANCE trial. So thank you so much. Welcome, Dr. Anzueto, to the podcast.
Thank you. Thank you for the invite. I'm looking forward to participating in this conversation.
Oh, great. Thank you. So before we dive in, since we'll be discussing nebulizers, I just wanted to go through a couple of the terms that listeners may hear about different inhaler therapies for COPD. So when we discuss inhaler therapies for COPD, there's several different types, including dry powder inhalers, which we call DPIs, meter dose inhalers, which are known as MDIs, and also there are soft mist inhalers, which are also known as Respimat devices. A nebulizer is a particular device which includes an air compressor, a cup that holds some kind of liquid medicine, and then air will pass through the machine and aerosolize medication into a mist, which patients can breathe in through a mouthpiece or a face mask. So nebulizers can be used in other medical conditions, including cystic fibrosis or asthma, but today our focus will be particularly on COPD. So the GOLD guidelines recommend that the choice of inhaler therapy be individually tailored for the patient, as we will be discussing today. So Dr. Anzueto, we wanted to really know, when you're considering a nebulizer versus other types of inhaler devices, such as MDI, DPI, or Respimat, how do you decide which is the best strategy for your COPD patient?
Thank you. Thank you, Amy. I think it's important to highlight also in the difference of the liver devices that the nebulizer that we have today is not like our grandfather used to have. It's not like a big box that's noisy, that takes forever. We have now a highly efficient nebulized system that allows the delivery of medications more faster way, 3 to 5 minutes, and also more effective way to deliver into the lungs. So at the end of the day, within the GOLD document and all the different recommendations for treatment in COPD, the interventions have to match the patient needs. And in chronic lung diseases, specifically in COPD, the challenge that we have is these medications have to enter inside the lungs. So how do we deliver those? That's got to be our priority, to try to identify, in my patient, the powder formulation will work, in my patient, the DPI, or in my patient, we have an alternative, we can give the medications nebulized. I mean, I also want to highlight one important issue. The US is the only country that we have available long-active anticholinergics, a once-a-day medication. We have available long-acting beta-2 agonists, actually 2 formulations of formoterol, and we have available nebulized budesonide to be used in adults. So we can reproduce in our patients the optimal therapy for the management of the condition using nebulization as another alternative for delivering the medication. So specifically to answer your question, how to decide which is the best strategy to our patients? This depends on the patient's ability to generate inspiratory flows. This depends on patient's coordination. Also, this will determine other conditions, patient concomitant medical conditions. For example, a patient who has severe rheumatoid arthritis, who would be very hard to handle some of the other delivery devices. So nebulized medication could be an alternative. So this is a combination of the patient's characteristics that will help us to determine, with the caveat that we can reproduce in any of these delivery systems most of the therapeutic areas.
Oh, that's so. I deal with this a lot with my patients, and I think that's really great to hear kind of how you summarize it. Like, so you're kind of putting it together, the inspiratory flow, coordination, comorbidities, those all kind of come into play. Are you, a lot of times when we have patients in clinic and we're not sure if they can mount like a good inspiratory flow, we'll test for that. Is that something you do in your clinical practice?
We do tests in clinical practice, and there is a lot of variability in the inspiratory flow. It's less than 30 liters, it's less than 50 liters that the patient is going to be capable to handle it. I think we have to also take into consideration the ability, of the patients to handle it. For example, in the powder formulations, we know that is crucial that the patient generates a good inspiratory force in order to separate the carrier, in the most cases is the lactose protein, from the actual medication. So the medication will enter into the lungs. In the DPI forms, the coordination to when you need to take the inspiration when you fire the device, that can be compensated somehow with a little bit with the spaces. But it's a matter to tailor to the patient's condition. It's not unusual, we prescribe X or Y medication delivery system, and the patient comes back and says, no, I don't like it because this and that, or no, I don't feel the medication is working on me. So we know that we have different alternatives, and it's very, very nice knowing that we can also have the nebulized system as an alternative to give these therapies to our patients.
So when you say, like you were saying earlier, you can reproduce optimal therapy with nebulized medications, and I guess highlighting that America is one of the few countries where you have all these medications on hand. Do you so while that seems really wonderful, I think, like you were saying, you have to kind of tailor your therapy based on the patient. So is there some drawbacks you see to using nebulizers?
Sure. Certainly for some people, you have to be connected to a device. There are some that are battery operated and they are portable, that you can take it everywhere. Probably one of the drawbacks is the fact that although in the powder and in the DPI form, we have now come to the point that we have the three major classes of medication being delivered at the same time in a single inhaler. So the LAMAs, LAVAs, and ICS, you have a powder and a DPI form. With the Respimat, we have the LAVA-LAMAs combination. Unfortunately, for the nebulized, we don't have formulations that are combined for long-acting bronchodilators. The only formulations that are combined are from short-acting, that is albuterol and ipratropium. But we don't have like a formoterol with the LAMA or the three medications together in a single vial. So that creates that patients have to receive 2 or 3 different vials. The patient really have to keep track of what do they use and how do they use it, because we don't have approval to be given combined. There was a study was presented back in 2019 in CHEST. That was some preliminary data to look at using the combination of long-active anticholinergic revefenacin with formoterol I think it's together in the single nebulization as well as sequential. But there have not been any further interventions or attempts to combine. So I would say the pitfall will be patients have to keep track of 3 different medications, have to use 3 different medications, and it's okay to use a sequential, but we don't know it can be used together.
Okay, so that was actually one of the things that I get asked a lot by patients. Like, can we mix? Can we mix medications? So my understanding was there's some of them you can mix the long acting, or is that's not recommended?
The only one that are being studied have been some preliminary studies with revefenacin and formoterol, but that has not been approved. They don't come together. They all come separate. So that is a major pitfall, that they come as a separate medications, separate inventories, separate copayments, and all that the patients really have to track of that, because these medications work to keep it all together.
Support for this podcast is brought to you by Viatris and Theravance BioPharma. Viatris is a global healthcare company with a mission to empower people worldwide to live healthier at every stage of life. We provide access at scale, currently supplying high-quality medicines to approximately 1 billion patients around the world annually and touching all of life's moments. With our exceptionally extensive and diverse portfolio of medicines, a one-of-a-kind global supply chain designed to reach more people when and where they need them, and the scientific expertise to address some of the world's most enduring health challenges, access takes on deep meaning at Viatris. Theravance BioPharma aims to transform the treatment of specialty respiratory and neurologic diseases through the discovery, development, and commercialization of medicines that make a difference in patients' and caregivers' lives. So like you were saying, you really have to, knowing that these haven't been tested together in great detail, really need to keep the medications separately when they nebulize. But sequential, yes. Right? They can do one after the other.
Yes, they can do a sequential one after another, but they cannot give it together to the patient. The positive side also is the fact, like for example, revefenacin once a day, formoterol is twice a day, and budesonide. So we're talking about that with the delivery system we have today. We talk about 3 to 5 minutes nebulization. So patients don't want to sit over there for 3 hours. Within 20 minutes, the most half an hour, they should have all the medication, receive all their medications.
That is a great point. I think what you were saying about the nebulizer device, because I've had patients tell me like, oh, it takes me like 10, 15 minutes for like to nebulize one thing. And I think at that point, you might need to say to your patient, like, how old is this nebulizer? Was it like a hand-me-down? Because the technology has moved forward where nebulizing medications occurs much quicker. Right.
That is a very good advice to tell them. And I tell my patients, I always ask them, do you have a nebulizer? How old is it? Oh, it's old. Let's get a new one. Let's have a new one available. In case you may use some albuterol once in a while, let's have a new nebulizer. Once they utilize a new nebulizer, high flow nebulizer that's highly efficient, they notice it's 3 to 5 minutes. Patients say, wow, this stuff is going to work, and gives them some, encourage them to try to use other alternatives for treatments that way.
Oh, that's a great point. And I think encourages adherence, which is one of the things we're worried about when we're ever trying to prescribe a medication.
Yeah, so adherence is huge, and it's a big challenge on all nebulized medication. I'm 100% convinced that my COPD patients, adherence is not a challenge for them. The fact that they will choose not to take the medication because, I don't feel like getting it, because they understand that taking the medication, they want to feel better. The challenge of adherence on the patient sometimes can be medication acquisition, cost, the copayment changes. I always ask my patients, are you able to take your medications? And they say, no, the copayment increase or whatever. I always tell me, I will go shopping. I will find you samples. I will find your ways. We will look into in your plan to see what is the medication to be on the lowest copayment, because the adherence at the end of the day is because the difficulty of the acquisition of the medication. But the patient understands that they have to take the medication, and they have experienced the much better, feeling much better using these medications.
Mm-hmm. Yeah, no, I agree. I think a lot of patients it's just such a struggle after they see us. So I think we have in our clinic, we have a pharmacist who actually kind of follows up with them. And there's just a lot of the times things kind of get lost in translation, and just with insurance and all the push, things may not be covered. So things get switched. Maybe we don't hear about it. Yeah, that's a common issue, unfortunately.
I try to shortcut that circuit. So I tell my nurse, my medication needs this class of this is a class of medication he or she needs. Let's look into the insurance, and I will sign an order of a medication that I know is part of the low tier of his insurance, her insurance. Because once the patient goes to the pharmacy, they found this huge copayment. They won't take the medication. They will get upset. Everybody's going to get upset. So at the end, the patient is not going to get benefits. So I always encourage my providers, let's try to shortcut that system. Let's try to identify, let's take another 3 minutes to identify what is the medication that his or her insurance will have the lower copayment. And that's the one we should prescribe. Mm-hmm. Very often, nebulized medications will fall into this Medicare Part B, and in Medicare patients, this will have the lowest copayment. So that will also have, even using the nebulized alternative for a financial reason, in some patients could be very advantageous.
Yeah. That's a good point about how usually so almost always the nebulizer device can be covered by Medicare as Part B, as long as we kind of document appropriately that it's clinically needed and everything like that. And then medication it's a little less clear if it's covered, but usually you have a good chance, right?
Yeah, most of the time you get coverage for that.
Yeah.
Nebulizers, I haven't had any problem getting the patient nebulizers. Almost even private insurance all covered those nebulizers. That is something very standard.
So when we talked earlier about comorbidities in COPD, you had mentioned like rheumatoid arthritis or those kind of patients. You may worry that they can't tolerate other inhaler therapies. Is that something you've noticed for like COPD patients with like muscle weakness, muscle wasting?
Coordination. I have prescribed a long-active anticholinergic for the last 25 years. So they come in a blister. And I have never saw a blister or put out a capsule for a blister. One day a patient came and said, hey, have you ever tried to put a blister out of here? I say, no. Okay, please try to pull it. And he says there, if you pull more than one, you have to discard. I mean, it was very hard to pull, and I pulled 3. So I messed it up 2 days of his treatment. So those little things, that really we have to take into consideration that, in your fine-tuned and your fine motor coordination, you have bad rheumatoid arthritis, you cannot use those devices. And we have to remember that our COPD patients, most of them only have COPD. Their 70s is very likely they have significant cardiovascular disease and many other. They are taking 6, 8, 9 medications. So how do we facilitate our interventions, our treatments that will be a benefit for the patient? So at the end, sometimes I think myself, I go over the medication list. It's endless. Go down there and say, okay, what can I do from the pulmonary point of view to facilitate that the patient don't have to worry the least as possible. Even a lot of refills. usually get 3 months. I get always refills. I keep an eye on those ones. And then try to get delivery systems and way to deliver it to be very, very handy, very friendly to use by our patients.
Mm-hmm. Yeah, I think so. One of the unique things about COPD and other lung diseases is that you use inhalers, right? That's one of most other medications you can take a pill and derive the benefit from there. But yeah, I think that's what makes things more important for us to address in the clinic with our patients is how they're actually using their inhaler, which is and that's also something we also need to follow up with our patients, right? Like once we've taught them, we need to follow up in clinic, just double check that they're using things properly over time, right?
Yeah, for example, in the delivery systems, in one delivery system, patient had to breathe very fast to get the medication. But in the mail, the insurance change and give a delivery system, like for example, the soft mist, if they breathe fast, they won't get the medication. So that's what I think is very important. Every time we see the patients, try to ask them how does medication look like, how do they use it. There is a study published from a clinic in Germany. When the patient check in, there is a small screen, a computer screen, and ask how do the medication looks like. So they press a picture and it gives them 90 seconds. This medication, you're supposed to do this, and this. That by itself significantly increases the compliance of the medication use. So these are very low-cost interventions that can have a huge impact on the patients.
Yeah, that's true. I mean, it's great if you have time to go through it with the patient, but there's also videos, right? Like there's videos on YouTube. You could show your patient maybe while they're waiting to,
Right.
So there's I think a lot of ways we can tailor our practice to really help emphasize the teaching as often as we can.
That's correct.
Yeah. Well, and just to get kind of think about the future, where do you kind of see nebulizers going into the future? What are the things that you're really excited about in nebulizer medications?
So I think it's exciting to know that nebulizer is an alternative for our patients. We have the new phosphodiesterase inhibitor, the phosphodiesterase 3 and 4 inhibitor that was delivered by a nebulizer. And the Achilles tendon of the oral phosphodiesterase 4 was side effects. All type of side effects from gastrointestinal to weight loss to psychiatry issues. And all that can be overcome using the nebulization. So I think the nebulize provides to our patients an alternative of care that we can achieve maximal efficacy with a minimum side effects. Our C nebulized, as you said before, on CF, antibiotics have been used nebulized for a while. We have a medication available, nebulized amikacin, for the treatment of patients with a MAC, an atypical mycobacteria. So I think we are discovering more and more that nebulization for respiratory conditions is a good alternative that allows the position. And all this is because these new delivery nebulized systems are highly efficacious and very efficient.
That's great. That's a great point about the devices and how they've really moved. The technology has really improved with them. So I think that's something always to think about in our patients who may be using an older device or have a hand-me-down or something like that. So, well, thank you. Thank you so much, Dr. Anzueto, for your lending your expertise to the podcast, for the expertise in all things COPD. But thank you for focusing on nebulizers today and really helping us clarify how to integrate these into our clinical practice.
So, Amy, I think it's important to highlight that COPD is a treatable disease. There is a lot that we can give to our patients. We have terrific medications that we have developed the last 20, 25 years. The advantage is we know the efficacy, we know the safety, we have identified the appropriate doses to deliver a system. So we have all these choices to our patients. And nebulization is part of those choices to give optimal therapy for our patients, control our patients, control the condition.
Yes, absolutely. I think it's such an exciting time for COPD. And I think that we have so many new tools in our toolbox to help our patients and just really make them feel better and help them move forward with their disease.
Thank you for joining us today. To learn more, visit our website at thoracic.org. Find more ATS Breathe Easy podcasts on Transistor, YouTube, Apple Podcasts, and Spotify. Don't forget to like, comment, and subscribe so you never miss a show.